Welcome to session 5, where the focus is on STAR Apollo Mapping System, a novel strategy for AF activation source mapping. For this session, we're going to review a case myself and Richard recorded recently. Before we start, I want to welcome back our panel, Richard, Atul, and we will have Musa join us soon. We'll go on to the case. And I'll share my case here. If we can start the first slide deck there. Thank you. All right. So just to kind of bring up what star mapping is. Star mapping is a technology that pretty much summarizes AF activation during 30-second recordings. That's the simplified way of looking at star mapping. Now, Richard has a lot more to say about it, but this is what my takeaways are from what star mapping does. What can it do? It can show you activation patterns. It can show you sites of localized activation. And while it does this, what does it ignore? It ignores low voltage and scar. It ignores infrequent phenomena. And recordings that are too short or where the catheter is unstable or has poor contact. And errors of timing interpretation are overwhelmed by repeating patterns. So how does it do this? So it takes the 3D geometry from the case, and it is able to show you where the location of the recording and the electrodes are. It is able to show you the dominant activation patterns, which are shown in this kind of purple arrow. And it's able to show repetitive sites of local activation, which are shown as these bright red spheres. Recording and electrode numbers and other characteristics can also be available if you want and if you ask for it with just a mouse click. So what do these sites mean? So early sites of activation is what it means. These are highly repetitive sites with early activation emerging within the footprint of the mapping catheter, such as that you can see this activation spread in all directions within your mapping catheter. For example, when you have the grid catheter, you see the activation spread within that grid catheter. And the early sites of activation are ranked according to the repetition count, and they're represented by these red spheres. And the larger the sphere, the more repetitive it is, and the more earliest it is within the activation platform. What do you mean with repetitive patterns of activation? These represent a summary of the two most dominant directions of activation wave through the footprint of the mapping catheter as well. And this is recorded, as I said, during that 30-second recording. These are represented by the purple arrows. Again, they've made the system very intuitive with the arrows and the spheres. And the thicker the arrows are, the more repetitive it is. And these repetitive patterns of activation helps us identify the direction of potential AF sources that we might not pick up with just the early sites of activation. So I want to present our case that we got to do together. And it was truly my privilege to have Richard come over from London to Jonesboro, Arkansas to do this case with me. So it's a 78-year-old female with CAD and PCI, had hypertension, diabetes, so a lot of risk factors. She had paroxysmal atrial fibrillation, had a pulmonary vein isolation with radiofrequency catheter ablation in 2011. And she'd maintained sinus rhythm with antiarrhythmic therapy. And I'll say that at that time, we used the lasso-based ablation strategy. It was putting a lasso catheter and going around the lasso and ablating around the lasso. She did have recurrence of atrial fibrillation in 2020, and she was started on sotalol at that point. She ends up having recurrence of persistent atrial fibrillation in December of 2022. And despite high doses of sotalol and amiodarone and failed cardioversions, she stays in atrial fibrillation. She ends up having a worsening ejection fraction and decompensated heart failure, which is something that we see in these patients quite a bit. And at this point, she's referred for a repeat AF ablation. And I want to take a moment and do our poll here, if possible, before we go on to our case clip. So I want to just kind of ask the audience what their thoughts are with our poll question. For a repeat AF ablation procedure, what is your treatment strategy currently? Are you doing PVI plus cafes? Are you doing PVI plus lines? Are you making a combination of lines and cafe along with the PVI? Or is designing the lesion set a more of a challenge and has to be more customized? So please vote on this poll question, and I'll go forward with the case presentation, and we'll come back to the answers of the poll. So Richard and Atul, feel free to jump in as we're doing this case and comment along. And I'm assuming Musa is going to join us soon as well. But here you can see we're doing a baseline voltage mapping, and you'll see that as we're moving, this is actually using the Insight X system and the grid catheter, and that's what the star mapping system is integrated with. For its use. And so we collect our baseline voltage mapping. You'll see as we're looking at the voltage that this is a very, what I would call more of a PV ostial isolation, kind of how we used to do them a long time ago, not the routine antral isolation that we do now. But it's surprising as we've seen in the earlier sessions, and we talked about how sometimes PV isolation is all the patient needs, and the patient actually did really well for a very long time, and obviously now is in a different state. And any thoughts on what our poll question was before, as you watch the mapping being performed here?
I don't have any particular thoughts on the poll question. You know, maybe a none of the above might have been a nice option as well, because I'm not sure that we necessarily know what we're doing. But you know, it's very interesting to me as I'm watching you collect this sinus rhythm map, that the voltage outside of the veins seems pretty normal, especially given the presentation. You said she came back with persistent AF, heart failure, decreasing ejection fraction. And, you know, it just goes to show how, you know, we still understand so little about the substrate of AF and you know, the clinical presentation. Because if you'd asked me to guess what her sinus rhythm map would have looked like, I would have thought it's just diffusely diseased, and I see a lot of purple there.
Yeah, so this is an AF map actually. The voltage gradients are pretty low. It's at 0.15.
Okay, all right. Okay,
we're speeding it up a little bit. So sorry about that. I should have told you it's at a 5x speed that we're doing the map, and that is a great point. We'll see the sinus map at the end. But what you're seeing here is we're now starting to do what we call the star mapping. And Richard, feel free to jump in as we do this. But the idea is that you collect your pre-voltage, you create the shell of the atrium, and then you identify different areas with the grid, and you sit still for 30 seconds, which I think Richard saw was the hardest thing for me to do, is sit still for 30 seconds. But you can see on the timer on the bottom, it tells you that you kind of hold the catheter in place, allow the system to collect the patterns within the grid for that 30-second window, and you're going to multiple sites. And I'm kind of doing it in a little systematic approach within the anterior wall, going to the posterior wall, coming along the antrum of the pulmonary veins, the base of the appendage there, and kind of systematically collecting about 15 sites or so, and letting the system take the time getting that data within the Insight X system at this point. Any thoughts on the mapping aspect here, Richard, that I missed?
Yeah, so yeah, well, so I think it's important for the audience to remember that where the map is based on the unipolar electrogram timings, there's no filtering or secret processing. And what we're really doing is showing the patterns of activation based on those unipolar electrograms. And if you remember the old studies of Alessi using epicardial arrays on surgical patients, how long it took Michel de Groot to analyze those data just for a few seconds by hand. It's an incredibly time-consuming process. And as we get more data endocardially from things like the grid, it's becoming humanly impossible to really assimilate all the data. So what we're really trying to do is to give you a summary of what's been happening for the last 30 seconds. And because it's recorded for a reasonable length of time, patterns that repeat themselves become more and more obvious. And unlike current vector propositions that are shown on some of the maps, which are just showing you the vector in real time, we're showing you a summary of what the vectors and the activations have been doing over a longer period of time. And the hypothesis being that if something's repeating itself over and over again, it'll come out and you'll be able to see roughly the area of the atria that it's emerging or originating from. And therefore you can then cluster your lesions. So this system is not, it's blind to mechanism. It just wants to know where the location of the activations are emerging from.
Yeah, so I think, when I was, it's interesting because if I start looking at cafes, and obviously in AF, it's very hard, but when you go back and look at when I look back at the cases that we did, what I would have thought of areas as early sites is not what I saw the system recognize. So I think there's definitely the fact that you have AI involved, and makes it easier, that the human eyes don't process. I think that's the beauty to me.
Yeah, it's a good point because cafes, we don't know whether cafes are an origin with a very fast activation or they're created by collision of wavefronts and are passive. And so what we're really trying to do is distinguish between those areas that look really interesting, which ones are the ones pushing activation out and which ones have activation coming in towards them and colliding.
Yeah, I'm wondering whether we should take a look at the audience poll and see what the audience thought. And maybe you're right. None of the above is what we should go for. It seems like PVI plus lines kind of takes the huge vote, but there is a large majority of us that still have a hard time figuring out what to do. And I think you're right, Atul, when we talked about whether we know what we're doing. I think outside of PVI, it's still a challenge for us to know. And I think that's kind of where I want to highlight this next part of this video series to show what the map showed us. Can we please go back to the video here? Thank you. Right, I will go on. So
Richard,
here we're showing. Go ahead, Atul. Go ahead and pause that.
Oh, no, I was just going to say, I'm glad that you chose to analyze the unipolar electrograms because, when we think about what's happening, ideally, we would love to see the action potentials, and to really understand what's happening. That's not practical. But I think the unipolar activation really gives us a better sense of what's happening at that MAP level than the bipolar electrogram could ever give us. And, in the bipolar, we can get very, very confused, especially in these cafe areas, about what's really going on.
Yeah, that's a great point. And just to talk about just the practical side of how this gets transferred, the map, the data that's collected in the InsideX system is transferred onto the STAR mapping system, and takes about 10 minutes for Richard to give me his STAR map, which was incredible too. And just a thought on that, Richard. I mean, is there plans of making it more bidirectional, optimizing that workflow a bit more, where it's all one package?
It's a great question.
Or am I in
Almost as
trouble?
I paid you to ask that question because we have, we have a FDA submission in to take the data directly from an Ethernet cable live from Insight. So the map will update itself as we go along. So what will happen in the future is that you'll be able to then decide which direction you move your grid based on the RPAs and what they're pointing to. So it'll be live in Q2 next year. Checks in the post.
That's great. Yeah, let's play the video back up again. So here we are starting to see the star map here, and we're starting to look at early sites of activation and the patterns of activation as well. And you can see we're highlighting some of these areas. Here we are looking at the anterior septum along the right antrum, and also in the anterior LA wall. You can see the repetitive patterns, the two that are being highlighted that are kind of crisscrossing each other. We're seeing the early side of activation along the right superior anterior antrum. And as we come into the posterior wall and along the posterior roof, especially along the right superior pulmonary vein, we're seeing those early sites of activation again, but also repetitive patterns of activation emerging from there in kind of both directions, which I think is also very interesting. We're looking here along the base, along the anterior base of the right inferior pulmonary vein, again, seeing some of those patterns. So these were kind of the patterns that we identified. Anything more on the star map, Richard, that you want to add along?
Well, what was, I think was really interesting is that this patient who had an osteal isolation still had a cuff of tissue around the outside of the vein, which you'd identified, and the activations are going into the vein. They're not coming out of the vein. So clearly those RPAs, you can see they're consistently pointing towards the vein rather than out. So the deep in the vein cannot be the source.
Yeah, I mean, this, sometimes we'll talk about doing a repeat PVI, but I think this is a great point that you made, is the PVs were probably not the source. And at this point, what you're seeing is actually tagging these early sites of activation and these repetitive patterns of activation onto the Insight map. So you're taking those points, and you can clearly look at where the catheter was at that point, pick up exactly which electrodes we need to tag. And what you're seeing there is my clinical team taking those points and giving me little markers, and they're marked in little green dots. And once we put those green dots in place, I'm kind of customizing my lesion set. I wanted to make, as Richard said, there was a pulmonary cuff there, so I wanted the right-sided antrum to be a little more wider. But I created the lesion set, or drew the lesion set, incorporating the early sites of activation and those repetitive patterns within my target lesion set. And we're using a Tactiflex ablation catheter here. And it's a single transeptal technique, and we kind of had this discussion early on in today's sessions. I'm a single transeptal axis person. I try to get my first pass isolation and then come back with the grid and check. And I think there's obviously two ways of doing it. You can obviously have your grid in there as well, but we're applying 40 watts in the posterior wall for about 10 to 12 seconds, and about 50 watts in the anterior wall, more stacked lesions in the anterior wall as we're coming along that anterior antrum. And I think I want to take a moment as we get to that anterior septal area. This was one of the areas that we had identified that had a lot of early sites of activation, and also some really interesting paths, especially with the signals going into the pulmonary vein there. And so the question is, how wide do you come? And if you do decide the antrum, how do you decide your antrum? So to me, this is, even for a PVI alone strategy. I know for this case, I used a redo case, but I would think that there's some value in assessing where that PVI maybe need to be. Any thoughts on that? And before I miss that point here, you can see as we are in that area along that right superior that we actually convert to atrial flutter. It's an atypical atrial flutter here. And you'll see we're now doing the roof line just because that we had that early sites of activation along the roof in both the right superior area. And as we finish that roof line, you'll see us terminate as well. But as we watch this map, any other thoughts on the idea of incorporating this into a lesion set that you kind of have in mind?
I mean, for me,
Yeah,
the
so
goal
maybe
is
if I
always-
could
You go ahead, Atul.
maybe if I could just ask a question to both Richard and Devi. So are you just trying to incorporate those red or orange dots, or are you also trying to incorporate the arrows? And if so, you know, which arrows do you kind of give preference to?
So the arrows are an indicator of directionality only. So if you see arrows where the activation is spreading from one location in lots of other, spreading away, then the arrows could indicate there's a region that activation is emerging from. So that's one of the things we look for. The early sites of activation could be a focal activation. It could be epicardial breakthrough. We're not able to distinguish. But if you see a red dot and arrows going away from it in both directions, that's a further encouragement that may be another source of AF. So in this situation, Devi felt that our goal was always to try and do the minimum amount of ablation and leave the patient with as much natural atria as possible. And as we saw during the voltage map, their atria was very normal. And so Devi's plan was to use the PVI that she wanted to do and also encompass those early sites of activation within it. And it turned out that that's what organized the patient back into a regular tachycardia.
And I think we talked about this before as well. I'm more a minimalist when it comes to ablating in the atrium. Try to do as much as I need to. And I think to me that was, we pointed early that the voltage was normal. So I did not really want to do any more than what we needed. And we did see those activation patterns along the roof, which is why we did the roof line and we terminated with the roof line. And we ended up doing a flutter line in this patient as well because they had clinical flutter at one point. And our final lesion set ended up being PVI, which was a more wider antrum coverage, and then a roof line, which we showed that was blocked using the omnipolar mapping, and then a CTI, which is probably not what I would have maybe done if I had not had the mapping tool. And it's kind of, I'm starting to realize that I probably need to have more input than just anatomical ablation, especially in some of these redo cases. And just to kind of show some data, don't want to take a lot of time on it, but this is data from Dr. Hornibroch and his group looking at outcomes, long-term outcomes, comparing just conventional therapy. And what they considered as conventional therapy is if you took persistent AF ablation patients and divided them to just de novo persistent AFs and going in for radiofrequency ablation, there was a PVI cohort, which they looked at subgroup analysis. But the conventional group could either have PVI or CAFEs, PVI plus a line, or PVI plus CAFE plus line, or they could have ablation guided by star mapping. And you can clearly see from the graph that the recurrence from atrial arrhythmias was much less with when the star mapping technology was used in this patient population. And I think our at least our few experiences that we've had, we've been able to utilize the technology to get a very targeted approach in my mind, rather than just an anatomical approach, especially in patients that we don't really have a substrate to go behind. Just my thoughts on it. I think to me, the system gives me a summary of activation data. I think it helps design a more customized treatment plan, like you saw in our case. And like Richard said, it doesn't make any assumption on arrhythmia mechanism, and does not prescribe any standardized treatment. I think it's up to the physician and the operator to look at those patterns, look at the early sites, and then look at the voltage and kind of decide a better strategy for that patient, rather than just taking an anatomical approach. And I think there's definitely future developments that are looking at clinical outcomes, and we are looking forward to being part of the study that's going to evaluate the STAR technology for our redo population. Richard, any kind of final thoughts on the technology? And Atul, I want to take your word as the final word before we wrap up this session.
Well, I'm glad that Atul's going to finish, because I'm a kind of disciple of his studies, because I'm a great believer now that less is more. And I think that there's a sort of sweet spot where you do enough to stop the AF, you do more, and you're creating substrate and creating disease and making the situation worse. And I hope technologies like this will help us become much more focused and targeted. And again, I'm trying to move people away from the idea of AF termination. Although it's an attractive thing, we mustn't chase termination. We must try and chase the most important drivers, cardiovert the patient, and allow the rest of the atria to recover. And I hope that this will help to do that. Over to you, Atul.
Yeah, I'm glad that we haven't given up on mapping. When we were having the earlier discussion on PFA and how we can just do lines and huge swaths of the atrium, I think it's important to realize that we shouldn't dump all of the mapping knowledge and understanding of atrial fibrillation that we've had before. So I really hope that, in the PFA era, we are not going to forget mapping. We are not going to forget how to be electrophysiologists, and that we continue to use technologies like this one to help us identify the drivers in atrial fibrillation.
Well, I want to say thanks, Atul, for. This is a great way to end our session, and I just want to take a minute to thank Atul for spending this time with us. And Richard, can't thank you enough for coming down and being part of the case and being part of the panel, and having this great discussion for this tough case that we had. Before we close today's meetings, let's take a quick look back. Go ahead, Richard. You wanted to say something?
That day, Debbie did 15 cases. It's phenomenal going to Jamesborough and seeing her work. She did 15 cases that day and another 15 the next day, all AFs and complex devices. It's quite phenomenal to see her work.
Well, thank you, Richard. You're very kind. But before we close today's proceedings, let's take a quick look back at day one.